We have two orations. One is Dr. C.E. Oommen Memorial and T.A. Alexander Memorial Oration. And it comes alternatively. This year we have the C.E. Oommen Oration. And as President of KSOS, the first session I'm going to chair is this session. And I'm very happy the recipient is none other than our beloved Shashikumar sir. Okay, I'm very happy that I'm starting with him as the participant. Now, before we go to the oration, let's have the introduction about this oration by Dr. Mahesh.
Thank you, Dr. Rajiv. As customary, I am going to tell a few words about the oration, and Dr. Rajiv will tell you about the orator. So, Dr. C. Oommen was a native of Chengannur who settled in Kannur, initially worked in Kerala Health Services and started Women's Eye Hospital in Kannur. With a multifaceted personality, Rotarian, president of football club, rifles club, kites club, etc. Very active in KSOS, organized state conference and CMEs, trained many ophthalmologists, and president of Kerala State IMA. Wife Dr. Mary Oommen also was the past president of IMA. Two sons are managing Women's Eye Hospital. The most important thing that he has done is he was the first president of Kerala Society of Ophthalmic Surgeons in 1973-74. This was the first office bearers of Dr. C. Oommen as president and Dr. Tony Fernandez as vice president. So on 22nd December 1974, Kerala Society, that time it was called Kerala State Ophthalmological Society, which was inaugurated by Dr. Benedict Risutti and in Hotel Dwaraka, Ernakulam, and symposium of cataract surgery was done on that day. So this year we have a prestigious, we have an eminent person giving the oration. I request Dr. Rajiv to.
And I would like to introduce the recipient of this oration, Dr. S. Shashikumar. I'm not going to read that. You can read it from there. Let me say something from my heart. That will be better, I feel. As I told in my presidential address about Dr. Shashikumar, he was my mentor in KSOS. And he guided me in every stage. He has held various positions in KSOS. As a treasurer, he cleansed the accounting of KSOS and handed over a very clean platform for me to build further. The reforms he introduced in the society has taken the stature of the society very high. And the zones for conducting the drishti was introduced by him. That's one reason we are sitting here today. Otherwise, Kollam would never had a chance to conduct drishti. So he's introduced so many reforms, and he's brought out the manual in KSOS so meticulously written that during inauguration, what the MC has to say after each person is introduced, everything from A to Z is written in the manual. And he spent half his life for KSOS. I shouldn't say half, 90% of his life for KSOS. And he is the best person, the apt person to receive this oration. And with these few words, I'm introducing dear Shashikumar sir, and I invite him to give the oration.
Thank you, Dr. Rajiv and Dr. Mahesh and the KSOS for giving me this honor. Pointer? No, that is there, but the pointer. Oh, pad. I am honored and humbled to receive this award named after the founder President of KSOS, I recognize the presence of my teachers, well-wishers, colleagues, and fellow ophthalmologists during this oration. My sincere pranams to all of them. Dr. Oommen was a towering personality in Kannur and have molded several ophthalmologists in the northern part of Kerala. I thank Dr. Raj Isaac Oommen, who generously responded when I, on behalf of the KSOS as its General Secretary, requested him to top up the award in 2008-9. As I stand before this August gathering, my memories go back to my alma maters. After my MBBS at Medical College Trivandrum, I did my DO in Calicut Medical College and my MS in the erstwhile Government Ophthalmic Hospital Trivandrum. The facilities in these places were not very great at that time, unlike today. But we got lot of hands-on chances which gave us the confidence to start our surgical career straight after our PG. I am indebted to my teachers, seniors and colleagues in these institutes for guiding me and mentoring me to reach where I am today. I also owe my respects to the management of MOSC Medical College. Right now it is a medical college. At that time it was a medical mission hospital, Kolancheri, for the unstinted support they gave me during my decade-long service there as the HOD and Project Director of Community Eye Care Services and the Rehabilitation Center for Blind and Orthopedically Handicapped Women. I owe a lot to KGR sir for guiding me in understanding the nuances of managing an eye hospital at Chaitanya Eye Hospital, Ernakulam. His management skills were unparalleled. The ease with which he solved management problems were life lessons to me. He was more than a boss to me, and it took quite some time to recover from his untimely demise. Pranam, sir. I am also indebted to my team at my present institution, the Kochi Eye Care Center, Alva. All of them are ordinary people doing extraordinary things for the institution. I consider it an honor to serve our society in various capacities in KSOS. I believe I could do my level best for the betterment of KSOS, which is one of the most non-political, democratic and inclusive state societies in our country. And no wonder we bagged the best state society prize from AOS for the last 3 years. In the single specialty sector, ophthalmology is one area which sees a lot of startups. It is nice to know that many youngsters dare to start on their own, much earlier than the previous generation of ophthalmologists. Many of them find that starting a surgical center is an expensive affair. It is made all the more difficult by the guidelines issued by accreditation agencies. The OT ventilation is one area which jacks up the cost of infrastructure. I started developing interest in topics related to infection control after burning my fingers twice. I thought it would be ideal to delve on this topic today. Ventilation is a very vast topic, but what I like to cover in the next 25 to 30 minutes today are these: the basic concepts of air conditioning, objectives of ventilation and how to achieve them, the ventilation requirements for operation theatre and the current evidences in support or against them, infection control measures beyond the conservative things, alternatives for air purification, and what do the accreditation agencies say about this, and some recent updates. So before I begin my talk, I should stress on this: OT ventilation is not just air conditioning. And air conditioning is not just cool air. In the ancient times, warm outside air was passed through multiple earthen tubes, which were kept cooled by water, and this provided comfortable indoors. The buildings were designed to catch breeze by their peculiar structure. The air reached every part of the building to keep the inmates cool. But modern air conditioning started early in the 20th century by the invention of an apparatus for treating air by Willis Carrier. Modern HVAC system, or heating, ventilation and air conditioning system, it is not just cool air. It provides control of all these factors like temperature, humidity, pressure, air exchange, cleanliness and odor. So when we mention ventilation in clean rooms, all these factors have to be addressed. The basic principles of air conditioning: A refrigerant is used to transfer heat from the inside to the outside. The refrigerant is circulated through condenser and evaporator coils, and the cycle relies on its ability to absorb heat and as it evaporates and release heat as it condenses, a process driven by changes in pressure and temperature. The refrigerant has a low boiling point and freezing point. It is compressed by a condenser to high pressure gas with high temperature, and this heat is dissipated to outside air. When it comes back indoors, the refrigerant passes through a thermal expansion valve which suddenly decompresses it, and this is a Joule-Thomson effect, and the temperature drops there. It reduces the temperature indoors while passing through evaporator coils. So it is basically transferring heat from inside the room to the outside. And in a window AC, there is some amount of fresh air that goes in, but in a split AC, it is essentially recirculation of the room air. And there is no fresh air that comes in a split AC. What is the clean room concept in critical areas? The principles of OT ventilation is to dilute the pollution inside the room, to keep the particulate count low, provide fresh air, make the room comfortable for the inmates, and provide an aseptic environment. As I said before, all these have to be satisfied, especially in a critical area like an operation theater or ICU. And how do we achieve these objectives? To dilute the pollution, you get filtered, the supplied air is filtered, and to dilute the contaminated air, you add more fresh air. To prevent less clean air from neighboring rooms to enter the operation theater, it is by maintaining positive pressure inside the OT. And to create an airflow pattern that carries contaminated air away from the operation table, it is by providing laminar flow. And to provide a comfortable environment for the operating team, this is by giving proper air conditioning with controlled temperature, humidity, and ventilation. According to ASHRAE, or American Society of Heating, Refrigeration, and Air Conditioning Engineers, the internal air quality should be such that there are no known contaminants at harmful concentrations. Any problems that occur is a combination of source contamination, susceptible occupants, and a mechanism to transport the contaminants. Based on the internal air quality, clean rooms are classified. Operation theaters come under ISO class 5 and 6. Class 5 is the super specialty OTs, and class 6 is the general OTs. IOTs come under ISO class 6 or class 1000, where the permitted number of particles of 0.5 micron size is at rest is 1000. Proper ventilation should ensure clean, cool, dehumidified air under positive pressure with adequate air exchange and fresh air intake, helping to maintain the zoning in the OT. And zoning is important to minimize the risk of hospital infection, minimize the unproductive movement of staff, supplies, and patients. It increases the optimum utilization of staff and other facilities to ensure a smooth workflow. Proper layout and ventilation ensures that there is a differential decreasing positive pressure ventilation gradient from the inner to the outer zones, so that the cleanliness gradually increases from the protective zone or the outer zone to the operating room. Window AC is recommended only for comfort settings and not for critical zones. Split AC, there is no fresh air intake, as I have mentioned before. Other than the cool air and the other objectives of ventilation are also not met with split AC. Independent ductable units or direct expansion units are ideal for all small setups. Central AC, the establishment cost is very high, but the long-term running cost is less. And the air handling unit forms the heart of the proper ventilation system. It can reduce the particulate matter by filtering the air using a coarse pre-filter and a fine microwave filter so that particles up to 1 microns are removed. It can also process the return air and takes in fresh air also. There are heating oils inside to control the humidity. An outdoor unit supplies cool air into the system. So if a laminar flow unit is incorporated, which essentially is a box with a terminal HEPA filter placed above the surgical field, further filtering of particles up to 0.3 microns is possible and supplies a unidirectional stream of air at the surgical site. Using the pre-filter, which can filter up to 10 microns, the microwave filter, which can filter up to 1 microns, and a HEPA filter or high energy particulate air filter, This usually will have a perforated metal sheet for protection. Air changes, up to 10 air changes per hour are found to reduce air contamination by 99%, but NABH recommends an air change of 20 air changes per hour, of which 4 should be fresh air. If a laminar flow unit is not there, the flow at the surgical zone would be turbulent. And a LAF unit distributes the air in a single direction to an area around the surgical zone at an imperceptible velocity of 0.1 to 0.3 meters per second. And the flow is restricted to the surgical zone, which provides the room within a room concept. Contaminated air will not enter the laminar flow zone, which is the surgical zone. But then the LAF jacks up the cost by about 20 to 25% and 30 to 35% in annual operation cost when compared to basic code compliant conventional system. Code compliant I stress because it is not split AC. That is because the increased energy consumption needed to push in large volumes of treated air at high velocities through a dense HEPA filter, ensuring numerous air changes per hour. That is why the cost goes up. And the specific demands in OT are air changes of 20 to 25 per hour with 4 fresh air intakes, temperature of 18 to 21 degrees, a relative humidity of 45 to 55, and a pressure differential of plus 2.5 pascals. Having said all these, there are certain points to ponder. False ceilings in the OT is useful, but a time bomb if not done well. Contaminants from that space can leak into the OR if there is a leak, or if there is a gap in the box. Hence, good workmanship and periodic validation is a must. OT validation is usually done by a third party in line with the regulations of ISO 164441. OT has to maintain the test reports and the calibration certificates. These parameters, air velocity test, filter integrity test, particle count, temperature and humidity, and differential pressure have to be checked periodically, of which the other parameters need to be checked only once in 6 months, but the temperature, humidity, and differential pressure has to be monitored continuously, which will be displayed in the panel. What is the relevance of clean rooms for ophthalmic surgeries? Let us look at the evidences available. IOTs have some unique needs. Most common eye surgery is for cataract, and modern cataract surgery is a very short procedure done in a closed space. Still, airborne contaminants can get into the instruments and surgical field. Because of the unique anatomy of the eye, no systemic antibiotics can reach inside it. Hence, endophthalmitis is a nightmare for the surgeon and a catastrophe for the patient. So we have to spend any effort to prevent an endophthalmitis even for one patient. Particulate matter, microbes, and volatile organic compounds are the usual contaminants. Between 30 to 40,000 skin cells fall off from our body every hour. And this can form the nidus to carry bacteria. Microbes and particulate matter load will be more if the surrounding areas are polluted. Pollution by volatile organic compounds, carbon dioxide, and chemicals which are used for disinfection are not given due importance in most hospitals. Entry of airborne microorganisms, they can fall directly onto the wounds, or they can land on exposed instruments or on surgeon's hand and later can be transferred into the wound. The possible effect of different types of ventilation was studied on reducing the OT infections. In this meta-analysis on the effect of different ventilation, no significant difference in surgical site infection were noted between LAF and conventional ventilation in orthopedic and general surgeries. The study suggests strict OT protocols and discipline along with antibiotic prophylaxis more than a laminar airflow unit. But one thing to be noted in this study is that conventional ventilation means systems using AHUs without laminar flow units and not split air conditioners. In this large multicentric study reported in 2015, where 3 microbiological air counts, 3 particle counts, and 1 bacterial culture from the wounds were studied, significantly higher air microbial counts were seen in turbulent ventilation, but has not resulted in wound infection. The surgeries were done under cover of systemic antibiotics. That has to be remembered. In a recent study on the end-of rates in intravitreal injection, this was a report recently in August 2025, a 63.2% reduction in endophthalmitis was noted after using portable laminar airflow units. In this study, we reported in IGO, in an eye hospital on the necessity of HEPA to control post-op endophthalmitis. Of about 88,000 cataract surgeries studied, incidence of end-off is comparable in base hospital and peripheral hospitals. This also stress on standardized OT protocols more than a laminar airflow unit and HEPA. This is a recent study from Aravind Eye Hospital, which has become the talk of the town mainly because a huge number studied. Of the 4.5 lakh cataract surgeries studied in 14 hospitals, in 4 types of OTs, that is laminar flow with a HEPA filters, central AC with HEPA filters, central AC without HEPA filters, and split type of AC without HEPA filters, the end-of rates were comparable. The standardized infection control protocols are very robust in this study, which is very, very, very important. Other parameters like microbial contamination metrics and other indices of air quality like carbon dioxide, VOCs, etc. were not considered in this study. What is the effect of door opening on the particulate counts? Microbial counts are proven to increase in OTs where door openings during surgeries are more. In operation theaters with more than 10 door openings, microbial counts were 2 to 3 times higher. A quantitative correlation between air contamination and wound contamination is demonstrated. The laminar airflow pattern also changes with the disturbance in positive pressure differentials, allowing ingress of contaminated air from the corridors. It is reported in another study that a 1-minute door opening increases the particle concentration from 15 CFUs per cubic meter to 25 CFUs, taking approximately 4 minutes to return to 15. So why this study is important is because the door opening frequency is a modifiable factor which you can control by enforcing proper OT discipline. This study by Tan et al. Reported in 2022 studied the correlation between particulate matter and microbial counts. They report a positive correlation between particulate matters 5 and 10 micron size, which means that taking particulate counts can give a rough idea of microbial counts. It is easy to assess the particulate matter count, but taking microbial count is time consuming. What is the effect of poor ventilation on people? These were studied in office settings, not in operating rooms. As suspected, the carbon dioxide level increased with more people inside. In a meta-analysis on intellectual productivity, better ventilation correlated well with improved cognitive functions, especially in more complex tasks. Carbon dioxide levels is proven to negatively affect the cognitive levels much below the accepted occupational safety levels of 10,000 ppm. But these studies were done under controlled carbon dioxide levels in offices and not in real operating room settings. But still, the plausibility and risks are real. Don't you feel that most of the cases done in the morning when the staff and the surgeon are fresh goes off well? Are we seeing more complications late in the day? Can it be linked to disturbed cognitive functions and intellectual productivity? Maybe there should be a study on that for IoTs as well. None of the available studies in ophthalmology report both the measured operating theater CFUs or airborne microbial load and the measured endophthalmitis incidence with statistical analysis of the association between these two, specifically for intraocular surgeries. But the guidelines and reviews issued by the Royal College of Ophthalmologists, London, list inadequate ventilation as potential risk factors for surgical site infection. Now let us look at the evolution of evidence on laminar airflow. Most of the studies done in the earlier period showed that LAF decreased the infection rates, especially in ortho cases. But then the infection control protocols at that time were not very strict. Recent studies showed reduction in the airborne particles with portable laminar airflow units, and studies by Eraldi et al. Showed significant decrease of end-off with portable laminar flow units. Most studies, although report decrease in particle levels with laminar airflow units, that doesn't translate to significant benefit in infection control. So the key takeaways in laminar airflow in ophthalmic surgery would be fixed OT laminar airflow systems offer no clear infection reduction in modern clean settings with stringent OT protocols. Portable LAF devices create ultra-clean microzones, and clinical evidence also shows that LAF is safe but not very superior. Indian guidelines focus on HVAC systems and povidone in antisepsis and not LAFs. But the best practice would be to maintain a class 1000 air quality with strict aseptic protocols. What are the alternatives for air purification? OT etiquette, robust OT protocols score very high in infection control practices even in presence of laminar airflow unit. Ultraviolet germicidal irradiation and ionizers are adjuncts. This contains the fan filter unit is a device which contains a HEPA filter and a fan to blow filtered air over the surgical site. But there is no positive pressure, there is no cooling for which you will have to install a split AC, and there is no humidity control for which you will have to provide a dehumidifier. A portable laminar airflow unit is essentially a better constructed fan filter unit with pre-filter and grade 13 or 14 HEPA, which is mobile. It can be positioned to cover the surgical field, avoiding obstacles, but then this cannot replace an AHU. In split AC, since there is no fresh air supply, it can be supplemented with a treated fresh air unit or a TFA unit. This supplies fresh air and along with an outdoor unit can supply cool air. But then again, there is no dehumidification and pressure differential. Hence, these two cannot replace an AHU. Germicidal lamps are basically UVC light in the wavelength 254 nanomicrons, which is germicidal, but it lacks penetration and is harmful to humans. Effectiveness depends on exposure time and the line of sight. There are 4 types of UV lights. This is the upper room UVGI, installed near the ceiling to disinfect air that circulates upwards. This is the in duct. In the AC duct, you can provide the UV lights. It can be mounted inside the HVAC ducts to disinfect the air continuously. Mobile UVC units can be used for turnover cleaning between surgical cases and terminal cleaning after the surgical session. Surface UVC fixtures are fixed on the walls or ceilings, and none of these except the UV lamps in the AC duct can be used when there are people inside the room. Ionizers are devices which can be used in occupied rooms. They release negative ions which get attached to particles or microbes which get settled down or can be caught on electrostatic plates. It is not a substitute for AHU or other proper devices. Some ionizers release ozone which is harmful. So there is limited clinical evidence for its use in critical areas like operating rooms. Recently, one company has come up with a portable modular air purification system incorporating HEPA, UVGI, and ionizer modules. They claim to provide continuous air purification, giving about class 7 or class 8 purification, but can only be used as a supplemental device. So to sum up regarding this alternative thing, air stir units can only be supplemental. UVC lamps can be used for terminal or turnover cleaning. HEPA filters are an integral part of HVAC systems. Ionizers can be used, but it's rarely recommended. What do the accreditation agencies say? As per the NABH, OTs are general or super specialty. And NABH mandates AHU for all OTs. IOTs are general OTs, where they emphasize proper ventilation, temperature, humidity, and pressure differentials. And LAF is not mandatory in IOT, but adequate air exchanges per hour, positive pressure, and filtration rate is mandatory, for which you need an AHU. Innovative ventilation strategies have come up. Several innovations are coming up. Thermal guided mobile air supply units and localized exhaust suits improve air quality near the surgical sites. Internet of IoT or the Internet of Things technology is used for real-time monitoring and automatic adjustments of airflow based on the contaminant levels. Additional Ksos on the operating table prevent airborne contaminants from interacting with the patient. IoT sensors are used to measure the parameters in real time. The system compares live readings with predefined safe thresholds. If any parameter exceeds or is out of the allowed range, the ventilation system will automatically adjust the air supply velocity, and if it cannot be rectified, an alarm or notification is triggered, and this notification is sent to the WhatsApp number. So to summarize, inadequate ventilation in the operation theater is not a direct cause of endophthalmitis because the infection comes from patient's own flora or contaminated instruments or fluids. However, poor OT ventilation can be an indirect risk factor since it allows higher airborne microbial load. It increases the risk of contamination of sterile instruments, drapes, or surgical field. It may compromise overall OT sterility standards, especially if positive pressure laminar flow or HEPA filtration are not functioning. And it can reduce the cognitive functions, which most hospitals are not giving importance. Split AC does not serve the objectives of proper OT ventilation, and if the setup is big with multiple OTs working for long hours, it is better to switch to AHUs. The laminar airflow unit definitely reduces the particle count in the surgical field, which is most beneficial in orthopedic surgeries, but benefit in ophthalmology is still debated. NABH suggests AHU with or without laminar airflow unit. Focusing on maintaining very low theater air and surface microbial loads is still a prudent risk mitigation strategy. Adherence to meticulous OT protocols are more important than LAF units in infection control. We should address other objectives of OT ventilation also, like fresh air exchange, VOCs and pressure differentials, etc. More studies are needed to assess the effect of CO2 and VOC on cognitive levels of staff. And before ending, I would like to put up this slide once again, saying that OT ventilation is not just air conditioning, and air conditioning is not just cool air. Thank you.
Thank you, sir, for that wonderful presentation. He's known as the sterile person of Ksos. He's the ultimate as far as Ksos is concerned. It's a joke, Appa. It was a wonderful presentation. Is there anything, Mahesh, you want to add?
No. Actually, the moment it was shown, slides, Girir sir sent that and put it in our hospital group saying that the door opening should be stopped. Already he has put in the group. So each slide has take-home messages and we have to practice. So always prevention is better than treating endophthalmitis, which we do.
With this, we conclude the session, and we, as LOC, we want to give a memento to him, and I request Mahesh to hand over this